You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor.
In 2024, we are highlighting the Cancer Awareness Month in a special series.
We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regimen.
June is National Cancer Survivor Awareness Month, and our special guest speaking with us for this episode is Wendy Hobbie. Wendy Hobbie is a certified registered nurse practitioner and associate director for the Cancer Survivorship Program at Children's Hospital of Philadelphia. She has pioneered the development of the Cancer Center's comprehensive survivorship program and is internationally known for clinical expertise and research with long-term survivors. Can you tell us a little bit about your career path?
Sure. My career path took a dramatic turn when I went to graduate school at the University of Pennsylvania. Certainly, it's touted as one of the best schools of nursing in the country, and it lived up to its hype, so to speak. I had been doing adult oncology and wanted to switch into pediatrics and really had a focus on palliative care. And then my good fortune was to get placed for my clinical placement with Jean Ferguson, who was a nurse practitioner at the Children's Hospital of Philadelphia. And she was just the most magnificent mentor a person could ever dream of having. She was one of Dana-Farber's first nurses and used to regale us all with conversations of what that was like, but truly was the consummate teacher. At that time, this is in the early 80s, she is working with Anna Meadows, who is considered one of the founders or pioneers when it comes to cancer survivorship, childhood cancer survivorship. I started working with both of them. And then upon graduation, Anna had gotten a grant through the Commonwealth of Pennsylvania and was developing what they call the Pediatric Oncology Network between Children's Hospital of Pittsburgh, Children's Hospital of Philadelphia, Geisinger Medical Center, Hershey Medical Center, and St. Christopher's Hospital for Children. And what that did was it took about 1,000 pediatric cancer survivors, and we did systematic evaluation of them. It was one of the earliest versions. Ira Kaplan was our computer scientist, and he developed a program so that we fed the program. For example, someone had a nephrectomy. The program would spit out that we should do a urinalysis, check that person's blood pressure, and do a creatinine level. And so it was one of the earliest ways of approaching pediatric cancer survivors in a comprehensive way with full evaluation. So that was a very exciting kind of first step into trying to systematically and in a very organized way follow cancer survivors. I said yes more than I said no to opportunities and had mentor after mentor who just helped me take different steps in my career. Jean first helped me get published. Jean was the first person who took me and had me speak at a national convention. And it was always Jean who really was the driving force in my career. I just fell in love with taking care of cancer survivors and their families and have never once thought, should I be doing something else? So I have had a very fortunate career path, but it is marked along that trail with spectacular mentors along the way.
And we understand that you were part of the initial team that started the Cancer Survivorship Program at the Children's of Philadelphia. Can you tell us more about that process of program development or just what that looks like?
Yeah. So again, timing in life is everything. And that was at the time when I was getting ready to look for my first job. And Anna had received this funding from the Commonwealth. And she said, would you like to come along and help me start this? And together, we began to establish a database. We had to be able to identify who were going to be the patients who came to see us, and then have an organized way. And initially it was just Anna and me. It was just the two of us. And intermittently, we would pull in nutrition or psychology or cardiology, whomever we needed to also take care of that patient. And in some ways, I think at Children's Hospital at Los Angeles, and I think at the NIH, they were also beginning to develop their programs. And so there was a lot of networking that was going on at some of these very big centers on what we should be doing. And again, only a handful of nurse practitioners working with folks like that. I think June McCullough was down at the NIH, and Kathy Riccioni was out at Children's in Los Angeles. And so once we stepped out of the CHOP system, we began to network across the country. We all started to work together as nurse practitioners and clinical nurse specialists, looking at, from a nursing perspective, what it is that cancer survivors needed. And some of my early kind of educational support things that were developed, one is with Kathy Riccioni, where we developed what we called Passport to Care, which is not the current Passport to Care. This was basically an oak tag, a hard, multi-level paper that was much thicker than standard piece of paper, where survivors could start to write down their history so they could carry it with them. Obviously, we've moved on to multiple generations since then. So I think it's important that, yes, I was part of that initial team, and that was an amazing opportunity. And it also opened up the opportunity to reach out across the country to others doing that work. And really, when you look at cancer survivorship, some of the earliest work, obviously, medicine and nursing were hand in hand in developing what we needed to do for pediatric cancer survivors.
I think something that we had shared in a previous episode, Dustin and I are both in that age group where we were diagnosed as in adolescent, young adult range in that demographic. I'm really curious if you could tell us about the transition for the patients at Children's Hospital of Philadelphia to what that looks like as treatment for adults at the Hospital of the University of Pennsylvania.
Just to back up a little bit, I think that it's a great thing when we can treat adolescents and young adults in the pediatric environment. I think that although someone might be 17, 18, 19, even 20, 21, I often feel like the diseases they get and the treatment approach is a little bit gentler and kinder than an adult institution. And again, that's not to cast any shade at adult institutions, but when you talk about the number of individuals who are being treated at a major adult cancer center who are 18, 19, 20, 21, it's a minuscule number compared to the other diseases that those cancer centers are dealing with, breast cancer, lung cancer, those diseases. I think that it's very helpful, but I also think that when that happens, the pediatric institutions have to make an effort to meet the needs of adolescents and young adults. We really have what we would call a three-pronged transition program at CHOP. For our individuals who are, we view, at highest risk for potential long-term effects or late effects of therapy, including children who have had brain tumors, children who have undergone multiple relapse, those who've had bone marrow transplants, neuro-oncology patients who tend to get a vast majority of our treatment modalities: chemotherapy, radiation, surgery, immunotherapy. We strongly encourage that they get transitioned over to the University of Pennsylvania, where there is a young adult cancer survivorship program. This is headed up by Dr. Zalda, who is a med-peds trained physician who sees the pediatric side with us on Wednesdays. She will see all of those 19, 20, 21, and 22-year-olds, and then she takes them and transitions them right over to the University of Pennsylvania. That really is a very nice transition for families in many ways. One is they begin to get to know who Dr. Zalda is before the transition. So even though they're switching institutions, they identify with her. I think that has created a very nice transition for us. The other prong of our three-prong transition is that somebody still needs lifelong follow-up care but is leaving the area. So again, in most of those situations, families will choose to say, once a year, I'm going to come back and see my parents, and then I'll connect with the Hospital of the University of Pennsylvania young adult program. Or we assist them to find someone in their local community Again, young adult programs are less common than pediatric programs, but we try to find programs in their local area where they can receive survivorship care. And then the last category are those individuals that we view at such low risk for any late effects of therapy that we can generally transition them back to their primary care provider. Often we're helping them find a young adult care provider because their pediatrician at 22 is, I don't follow this kid anymore. So we often are helping people find a good primary care provider who we then provide guidance to, whether that would be a child who had Wilms tumor, which is a renal tumor, and had one kidney removed and then got vincristine and actinomycin. The risk to that survivor are so small that long as they're seeing a primary care provider who's watching their blood pressure, their creatinine, their body weight, some of the general things that you would want to watch in a young adult, not necessarily someone with cancer, they can be followed in their local community. And that happens quite nicely. Again, with the Epic Share chart or chart share, I'm not quite sure what they call it, local folks are able to access the primary chart at CHOP. So that where we used to have to provide like this boatload of information over to a treating institution where we were transitioning a survivor, we are able to now have them just look into our system, and our notes are there to guide them as to what's happened to this survivor in the past and what needs to be observed or monitored in the future.
As I was listening to you talk about this transition, it dawned on me that I've had the same oncologist my entire young adult to adult life, and thinking about changing from pediatrician to an adult doctor, there must be like a little bit of a challenge. Would you say so?
I think there's great trepidation on the part of the family. They see that wherever your treating institution is, that's who you trust. They're the ones that got you to the finish line. And that's a place where when they feel they call in and they ask a question, someone at the other end knows their child, knows their family.
Yeah.
So certainly it's a step, regardless of whether they go over to Penn, Hospital University of Pennsylvania, or whether they go back to their community, they still feel this draw or connection to the primary treating team and then survivorship at that same institution. It is a big deal. I think that we try to reassure survivors that we're not going anywhere and that they can always reach out if there's a question or a concern. Truly, sometimes we do hear back from particularly very low risk for late effects survivors because they're back in the community. So we will get questions intermittently. We're trying to have children and there seems to be a problem. Did I get anything as part of my therapy that would cause a problem? Even though we've educated them before they've left, they still have those questions when things arrive. So I think that transition is a very big transition. But the reality is that these families have made multiple successful transitions. And we try to underscore that. You've gone from a family that had never had to deal with cancer to dealing with cancer. You've made the transition from on therapy to off therapy with your current team. You've then made another transition from off therapy treatment to cancer survivorship. And now you're going to make that transition from cancer survivorship to adult survivorship. And so we try to really reinforce to families that you really actually have skill. You have a skill set when it comes to these transitions. And even though they're uncomfortable, you have the ability to do this successfully. I think that it's very important for any pediatric treating institution to prepare the survivor for transition. So one of the things that we talk to families about is when a child is about 13 years old, at some point during the visit, we have the parents step out of the room. And what we explain to the parents, which is true, is this is our opportunity to help your child develop their voice when they're speaking to a care provider, because they may come up to some care provider who actually doesn't know that much about them. And the cancer survivor has to be able to have their voice and be able to advocate for themselves. And if parents stay in the room, a care provider will always default to the parent. So I always say one of the most important things that we do is empowering a pediatric cancer survivor as they age up so that they become the keepers of their story. Because ultimately, if they go to college, they move away, they have to be the keepers of that story, not their parents.
Wow, that's really awesome that they help these young kids start to build autonomy at age 13. So
Right.
I think it's great that they were preparing them for their adulthood. And on that note, I'd like to ask, what are some of the challenges associated with long-term survivorship?
That's a really good question. And what we can do here is divide it into two. What are the challenges for the individual and family? And then we can move on to talk about what are some of the challenges to survive.
Yeah,
So when
sounds
we
good.
think about I think one of the greatest challenges for survivors is coming back to the place where they were treated. And for the pediatric survivor, that can hold a lot of trauma, even for an adult survivor. There is a trauma associated with the hospital. Now, there are some families who like coming back because they see old faces, they see what they call their oncology family. And for them, getting to see that family and to come back and to have a checkup and to be reassured that everything is still okay is good. But there is still a subset of survivors who are quite traumatized by having had cancer and gone through cancer therapy. And it's very interesting because the data does not support that the individual who gets the most therapy is the most traumatized, which initially, as a young provider, I thought, but of course, the individual who has relapsed or had bone marrow transplant is going to be more traumatized than the person who is either a surgical cure or a surgical cure with 12 weeks of chemotherapy. And the reality is that doesn't bear out in the research. It is the individual's perspective of life threat. So that is a much bigger issue than just had radiation, had surgery, had chemotherapy. So I would say that from a psychosocial perspective, that it can be a barrier to returning to the treating institution for some cancer survivors. Insurance. Insurance has become increasingly a bigger issue. We have some survivors who are on state insurance in New Jersey, and they'll say they can't come to Philadelphia to get treatment. You have to find someone in New Jersey. Now, we generally are able to circumvent that with a case by case basis and just say there really is no one in New Jersey who does pediatric cancer survivorship. And so we often are able to get them to come see us. In addition, we do have a Voorhees satellite. And Dr. Jill Ginsburg, who's the director at the Children's Hospital of Philadelphia of Cancer Survivorship Program, she goes over there once a month and she will see some survivors right there in the New Jersey environment. We've also had to stretch ourselves to identify other institutions that have adult cancer survivorship programs, but not necessarily geared toward pediatric cancer survivorship. Sometimes insurance forces our hand to create that avenue for them. I would also say health disparities are a big issue. And I think that when we talk about the final frontier, I believe that equaling the playing field with health disparities is really the next big place that we need to go. We know there are health disparities up front in therapy. So if you're a family that does not have private insurance or does not have means, and you want your child to have proton radiation instead of photon radiation, the distinction there being proton is the most protective of tissue, where photon, although it's still very good delivery system, will damage more healthy tissue than proton radiation. If you don't have insurance or if you don't have the means to get to a center that has proton therapy, you're going to be treated with photons and thereby be exposed to having greater risk of late effects of therapy as you grow in age. So certainly that's just one example of health disparities. But finances, social economic status, all of those things get in the way upfront through therapy and throughout cancer survivorship. So I think that those are some of the biggest barriers that I have seen over the past few decades. And ironically, in some ways, some of those barriers are bigger issues now than they were when we first started. Because when we started 40 years ago, it was easy to say we're the only gig in town because we were literally doing it, learning as we went. So it was relatively easy to convince insurance companies that we were where this survivor needed to be. So insurance does get in the way of having good survivorship care. Institutions. So survivorship programs can't just happen because someone stands up and says, I want to take care of cancer survivors. Institutions have to financially support these programs. They have to assist in making sure that there is an adequate team that is put together, because we do believe that a consistent care team provides the best care, as opposed to a rotating system. Now, a rotating system affords many more care providers to see what cancer survivors are and learn from them. But I've always held this belief, and most of the people that I've worked with hold a belief, that cancer survivors deserve expertise that a consistent care team can deliver. So certainly an institutional support is very important. And finding care providers who actually have a passion for survivorship. So again, this might sound it's going to sound a little terrible the way I say that, but there's nothing more compelling than a bald-headed child. And in survivorship, the vast majority of our children, you cannot tell that they're a cancer survivor. The driving force behind where finances would be driven, and I'm not saying institutional finances, I'm just talking about whether you're fundraising for a program or things of that nature, it is often difficult to help society understand that cancer survivors require the same intensity, the same level, and the same kind of compassionate care throughout their lives that they achieved or they received while they were getting cancer therapy. So certainly finances become an important part. And there are many pediatric cancer survivorship programs in this country, several hundred of them, but there are many more institutions that treat children with cancer that don't have set survivorship programs. And I'm probably going to talk over into what are some important aspects of cancer survivorship programs, because it really makes sense to step into that right now.
Yeah, it totally makes sense. I did have a question about something you mentioned about the radiation.
Okay.
So you said the proton is better than the photon, and I'm wondering what would be the reason that they would do photon radiation? Since there are more late effects, there must be a reason why they go that direction with radiation.
Because you have to have delivering proton therapy requires a huge, I don't even know how to explain it.
If we could skip it then.
But in order to deliver protons, I believe they're taking electrons and it has to go through an exceedingly long tube. Only major cancer centers can afford that setup. And we have the advantage of being connected to the University of Pennsylvania. So Children's Hospital of Philadelphia does not have a proton machine. Penn has the proton machine. If you take a smaller institution that may not have a larger adult institution that they're associated with, they just don't have a proton machine. If you don't have a proton machine, you have to deliver photon radiation. So it's not that you're getting substandard care by getting photon radiation. That's not what I'm saying here, because photon radiation is still very effective. It's that proton radiation protects the majority of healthy cells. So the radiation will go into the tumor target and come out. It doesn't go beyond, where photon radiation goes through and through.
Yeah, it just sounds like another barrier to survivorship, right?
One thing that it reminded me of is that in Star Trek, there's those, I think it's the photon torpedoes. I may be wrong, but that was like the thought that when there is a real danger, that's the probe. Like that's what they're shooting out, is that photon.
Photon torpedoes versus proton torpedoes?
Yeah, I'm not a Trekkie. I think the best way to explain that is that it takes a very large amount of money to have proton radiation. And unless there's a major cancer center that is going to invest in a proton machine, you can't get proton therapy. And therefore, the default is photon.
And this is just radiation?
Say that again?
Is this just generalized radiation? Because I had gamma knife radiation to my brain.
Yeah, that's different.
That's very different. Yeah, I assumed it was different, but I was trying to, even for our listeners who are like, oh, I know of generalized radiation, I know of gamma knife radiation.
This is external beam radiation.
Okay.
So if you need to receive external beam radiation, right now the two big players are proton and photon. Okay. Also, there are extra things that they do with photon to limit by doing it from many different perspectives, different angles, so that they treat more of the diseased tissue and try and preserve as much healthy tissue as possible. It's just that proton does it better.
Gotcha. I hope that any of our listeners that are listening to this episode, they have any family members who are going to do treatment, they can be like, proton radiation is what we want. And if it's not here, please connect us to a hospital that has resources.
But that family has to also have resources. So imagine that
Yeah.
you need 5 weeks of radiation or 6 weeks of radiation daily, 5 days a week, and you have to go 500 miles away to get that therapy. You have to have the ability to leave behind whatever you leave behind at home, whether it's work, family.
Wow. Yeah. Luckily, there are some centers, like, not to name drop, City of Hope has like a living situation, like right outside their care there, but not everybody has the state of the art care. What are some of the important aspects to the survivorship programs?
So I think that the importance of survivorship programs, I'll overlap a little bit with the Institute of Medicine report, which is quite old right now, but still has stood the test of time and really does underpin the philosophy that I have had, that I grew up with, which is that we need to provide services for cancer survivors and their families that is focused on them. It's wonderful when we can do other things within a survivorship program, which is that we get to educate and train other professionals so that they can then go back and do survivorship care at their own institutions. And it's always wonderful if we can conduct research so that we are on the cutting edge of understanding what are things that we need to do better for survivors, or how do we change current day therapy so the chronically ill adults of today do not have to become the chronically ill adults of tomorrow. The IOM report also talked about having survivorship guidelines, and certainly the Children's Oncology Group has developed wonderful guidelines. I think it's in its 5th iteration, which brings together professionals across the country and actually the globe to develop guidelines based on treatment exposure. And these are reviewed, I think, every couple of years to ensure that the most updated information is available to individuals who are taking care of survivors of childhood cancer. There are a lot of educational links for cancer survivors themselves if they want to go in and look at kidney education and how you take care of your kidney, heart information, how you take care of your heart. So certainly we have made a lot of dents in the recommendations of the Institute of Medicine. One of the other important things the Institute of Medicine felt is that you want to design a system that is responsive to the survivor's needs, which is basically mirroring what I just described. I believe in a consistent care team, because with a consistent care team, you get a bunch of things. One thing you get is a consistent message. We have a team of 5 right now. And no matter who goes in to see whatever survivor, we have the same message that we're delivering. We believe in health promotion. We believe in health maintenance. And probably the most important thing is educating the cancer survivors so that they can advocate for themselves. I think that's the underpinning of our program. Certainly, we do a lot of clinical research with our survivors, but again, that's not the driving force. That is just happens to be a opportunity that bears itself out with our survivors. And the wonderful thing is the majority of survivors and their families are always looking to give back. And that always amazes me about these families. They have been through so much and in their young family's life, and yet they're always looking to how can I help someone else? How can I make it better? Is there anything I can do for you as a cancer survivorship program? So I'm always in awe of our families. Comprehensive care is very important. We're very fortunate at the Children's Hospital of Philadelphia that we have been able to build a multidisciplinary program where once a month we bring together an enormous team of care providers: cardiology, nephrology, pulmonary, I'm going to forget someone, genetics, nutrition, neuro-oncology, neuropsychology, psychology, social work. And we bring in our most complicated patients. And what makes them complicated is not that they're complicated patients, but their treatment has been very complicated and they have multiple healthcare needs. And we bring these families in on this particular day a month, and they see whomever they need to see in that day. All their studies are performed on that day. Their lab work is performed on that day, and then they're seen by the subspecialist on that day. And then our group rounds at the beginning of that visit, all the care providers, and at the end of that visit, and we come up with a plan for the family moving forward. And the families have responded in a very positive way because they're always coming and going to the hospital. When you have 4 or 5 different care providers, you're coming to Children's Hospital sometimes 8 times a year, 10 times a year. And this kind of reduces that number at least by half, I would say. So I think that having care providers across disciplines is very important so that if you do have to refer a survivor to orthopedics, nephrology, cardiology, you're sending them to someone who has an appreciation or an understanding that these families have already been through a lot. They tend to be very savvy, medically savvy, and that approaching a survivor is different than approaching a family who has never dealt with this crisis. I think that having a highly specialized treatment team as well as referral base is also something that comes when you have a consistent care team and a program that is in place and focused on the needs of survivors and their families.
I had this vision of what used to be WWF wrestlers, but now it's WWE. It's just that comprehensive view of just being able to tag in and really have that a multi-spear, to borrow on your language you used earlier, way of approaching that treatment or those appointments.
I think that the more flexible and the more inviting we can be to help other subspecialists see that there's a great opportunity to understand their subspecialty within the context of cancer survivors. I think that there are just millions and millions of cancer survivors because we have a very big cancer survivorship program. As I would imagine that places like Children's in LA and St. Jude and all the centers across the country where you're dealing with thousands of survivors. But I think that we do need to have other subspecialties developing expertise with childhood cancer survivors, not to mention adult cancer survivors, but I won't go there today.
One thought I was having about the benefits of having a childhood cancer is that you heal so fast when you're a kid.
It is remarkable to me. Having done adult oncology for a few years, the difference is night and day. There are some very unique aspects to being an adult with cancer, and those experiences touched my heart in a variety of different ways. But when I watch what children will go through, that children can be on the brink, literally the brink of death. But because they have such a strong restorative power, their bodies heal, regenerate, and it just is fascinating to me how you can take a child who you watch go through therapy and they become a cancer survivor and they look great and they have a quality of life and things are going well for them now. It is amazing. Kids will get sick, they'll vomit, and then they turn around and they find something else to eat. Where an adult is going to be like, okay, I vomited, I'm not going to eat, I'm going to stop. It's just, they just have a whole different perspective. And I guess a little bit of that is ignorance is bliss. For the vast majority, I wouldn't say all kids don't have any idea what's going on, but we treat a lot of kids under the age of 10. And by and large, they don't quite grasp the severity of what they're going through. And they still try to be kids. They're still in the playroom. They still want to play. They still want to color. They still want to eat McDonald's, sadly. I think that is an amazing feature of childhood cancer survivors. And certainly it's why I think that in pediatrics, you choose to work in pediatrics because there's an energy there that selfishly we get from families and patients.
And I was also just thinking the fact that kids are still growing. There's so much more healing happening when you're still going through growth.
So that's the sword that has two edges. So children are also at greatest risk for late effects of therapy because you are treating rapidly dividing cells. If you give radiation to a growing bone, that growing bone does not grow as well as that unirradiated bone. If you give radiation to a growing and developing brain, that brain will not work as well as if it had not had radiation. It is the sword that cuts both ways, that yes, they have an incredible healing power, but they also have a great risk when given certain therapies, more so than adults for late effects of therapy. And they have more years to live post treatment than the majority of adult cancer survivors. If the average age of adult cancers is somewhere in the 60s, and we're talking about kids all being diagnosed, if we use the cutoff of 18, there's many more decades of life to live. And their treatment impacting them might have a different effect than if I give high dose radiation to a 70-year-old. I don't so much have to worry about significant radiation mutations, because if they live to 85, they've outlived the life expectancy for people in the United States. But if I treat a 16-year-old or a 10-year-old with radiation, how will that impact them when they're in their fourth, fifth, and sixth decade of life? Those are the questions that we still have. So it is true that they are remarkable healers, but they also are at risk for significant late effects of therapy if we treat with certain treatment modalities in growing bones, brains, hearts, and things of that nature.
Kind of reminds me of those stories you hear of kids who break a bone, but they break one on the growth plate. And then they have one really short arm. So yeah, there are pros and cons to childhood cancers and pros and cons to adult cancers.
It's very true.
Wanted to ask if perhaps you could talk about the Institute of Medicine report a little bit more, and that lost in translation, some of the recommendations for cancer survivors.
Yeah, and so we have talked about some of those, and I don't have them right in front of me, unfortunately, but certainly developing evidence-based practice guidelines. That was a very important perspective. I think that they really wanted to make sure that programs were designed that were responsive to survivors' needs. They also recommended that all cancer survivors should have a summary of their care. And I think that many institutions, and I think that's probably one of the most important messages that the IOM provided, because I think no matter where you were treated, if you were treated in a small center or if you were treated in a community hospital, it is very important that every survivor have information about how they were treated. So you might say, gosh, how is someone going to go back and get that information? Medical records. Now, if you go through medical records, you're going to get a lot of superfluous information that you don't need. You don't need to see 400 CBCs that you had during treatment. But unfortunately, if you go through medical records, you should contact the treating institution. And if your provider is still at that institution, because all you really need at this point now is you need to know, was I treated on a particular protocol? And what was the name of that protocol? Because once you have that, you can actually go fishing and on the internet now and find just about everything you need. But your treatment center should be able to tell you what chemotherapy agents you received. Did I have surgery? Did I have radiation? What was the location of my radiation? So was it given to my chest? Was it given to my abdomen? Was it given to my arm? And what was the dose? Now, from a dose perspective, that isn't going to mean a whole lot to you as an individual, as a survivor, because in the context of cancer survivorship, you need someone to say, oh, that was a high dose. That was a low dose. We don't need to worry about this, or we need to worry about that based on the dose that you received. But I think that everyone really must have a summary of their care. And again, some institutions have what they call, I think it's called passport to care is what they call it. I think that they developed that down in Texas. I think it might have been MD Anderson with Dave Poplack. I'm not exactly sure. And that's a large summary of your care with a lot of details in it. It does require a healthcare provider to fill that form out for you. So I would think that most institutions would at least be able to give a survivor, this was your day of diagnosis, this is the surgery, these are the surgeries you had, this is the chemotherapy you had, and you need the cumulative doses of certain ones that might affect your heart, ones that might affect your liver, things of that nature, ones that might affect your fertility. And then certainly understanding if you had radiation, and the dose of radiation. Now, there are a lot of studies out there that have been done by several institutions looking at survivors' knowledge. And basically, most of those studies have said that survivors know basically what they had, but they're not very good about the specifics of what they had. And I think that as an institution that treats cancer survivors, I think sometimes it's hard for them to remember I got doxorubicin or adriamycin, whichever way the survivor would know that as. And this was my dose. And I just need to make sure that I don't smoke, I don't vape, I exercise, I maintain an ideal body weight, and really take good care of my cardiovascular health. Whether they remember specifically of whether they got doxorubicin, idarubicin, in some ways is less important than understanding I received a chemotherapeutic agent that could affect my heart. So there are some things that I think we can agree on, that it's important for cancer survivors to know how they were treated and what they were treated with. But I don't think we necessarily have to get so caught up in they have to know the exact name of what they received, long as they have a general gestalt. Again, when they leave Children's Hospital Philadelphia, they're going to have a summary of their treatment. So they're going to see it. It's not like I'm saying they don't need to have it. I'm just saying is that if we can really distill down for cancer survivors, what is the important information you need to have? What do you need to remember? And how do you take care of yourself for life? I think that's the most important aspects.
I wondered if you could speak to just how the pandemic has changed the cancer survivorship approach and maybe just how that relates to cancer survivorship.
So I think if we can say something came out of COVID, I think it was that we need to use virtual means of communicating with survivors, whether that be using text-based programs, whether that be using telemedicine. I know certainly that psychology and nutrition have used medicine very effectively since COVID. Certainly during the first 2 months, 3 months of COVID, we were doing a lot of telemedicine. And there are wonderful aspects of it. You can reach people, you can teach, you can give them information. The downside to it is I'm not putting my hands on the survivor. And I think that there is something that can get lost in translation when you can't really sit in the same room and sit face to face. But I think it's opened up a new avenue. And again, some people are already using it more in rural areas, but I think it said to us, it taught us that there is a place for this and that this can certainly have a positive effect. And we might be able to reach out to people who we ordinarily would not be able to reach out to. And again, I think it's better than a phone call because if you can see the family's face, if you can see the survivor's face, you can make a better connection. And certainly there are a number of studies that are ongoing currently about supporting survivors and follow-up care that they need through text-based systems where a survivor might be reminded to take their medication, or a survivor might be reminded that it's time for them to schedule their next appointment. I think that it opened up an avenue that I don't think we really thought about much before. We don't use it for visits that often. Occasionally we do at this point. One thing that happened during COVID that doesn't continue to exist is that a lot of states within our tri-state or four-state area gave us the opportunity to do it telemedicine without having a license in their state. Once COVID was at a low ebb, that ability was taken away from us. So you have to be licensed in the state in order to do telemedicine in that state. I still think it has helped us and it's helped individuals see opportunities that maybe we wouldn't have thought of before.
Excellent answer. Something that came to mind was just boiling down my own perspective of being a cancer survivor and what that really means for me. And I think a word that came to mind and that thought process was diligence and just making sure that I am staying on top of these health recommendations. I do participate in the childhood cancer survivor study. And really, it's an opportunity to then have those follow-up appointments with the subspecialties and other areas to then make sure that I am doing what I can to be on top of things and to be, like I said, diligent. Just curious if there's maybe a word that encapsulates cancer survivorship for the both of you.
Certainly for me, I see a persistence and a dedication among cancer survivors and their families. And again, in pediatrics, you rarely see the survivor on their own. Even when they're at that upper cusp of where we are going to see a survivor in that 20, 21, 22 range, you still see a commitment and a dedication to family and family supporting the survivor while also trying to give them some autonomy. It is remarkable to me. Diligence is also a really good word. What about you, Dustin?
Yeah, I guess survivorship, what's it mean to me? I think it means just being proactive with your care and taking care of yourself, self-care, making sure you get enough sleep. I work with a lot of clients in outpatient nutrition, and sleep is the number one decline on most of them. But yeah, self-care, I think, is a big part of it. I think as a cancer survivor, you think about that a lot more because you're not functioning quite the same way you did prior to treatment.
Yeah. And I think the other thing that came to mind while I was listening to the two of you talk as well is we can never underscore the importance of mental health. I try to talk to survivors and their families about mind-body connection. There's no disconnect between the head and the rest of the body. And if you're not healthy in your mind, you're not healthy in your body. If you're not healthy in your body, your mind is not going to be healthy. And I think that we have to help survivors get rid of the stigma of reaching out for mental health, reaching out if you need medication, taking medication, that you've been through the crisis of cancer, the trauma of cancer. And it's very important that we understand that, and again, you're both survivors. There is a dividing line in your life before cancer and life after cancer. And no one gets to judge which is better, which is worse. It's just different. And you're both living a new normal. You've both developed your lives and moved on beyond cancer. But I think that the mind-body care is important. And certainly Dustin's sleep is a part of that. Good nutrition is a part of that. And making sure that you are diligent and persistent in making sure that you're taking good care of your health and doing what you need to do.
Mental health is a big part too. I remember the stigma when I was a young cancer survivor. People who went to therapy were people who had a lot of problems. And I think that we've, as a society, have maybe gone away from that, hopefully. I'd like to think that a lot of people are getting care now. And luckily, there's people like Colin out there that is just like super passionate about survivorship, who happens to also work in the mental health field.
Oh, you guys, I swear. Thank you so much for that like summation of just having the importance of that mind and body connection. Wendy, I really did appreciate you hearing that. I do wanted to also state that self-care is very important. I think that in our responses there, we both touched on that being proactive, making sure that we're really taking care of our health, but then also taking care of ourselves in different ways. Thank you so much for this conversation, Wendy, and to really have that perspective on survivorship.
It's been my pleasure.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media at Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.